I'm hoping from your screen as the host that you'll be able to record this.
Yes, yes.
Awesome, thank you. So for those of you that are here today, before we really get things kicked off, I would be curious to get an idea or gauge of what you already know about single payer. So if you know absolutely nothing and that's why you're here and you're excited to learn, use the little reaction button. Just give me a nervous thumbs up if this is your first time hearing really anything about single payer. If you already know a little bit about single payer, you're supportive of it, you just want to learn more about the potential impacts in the world of pharmacy or for pharmacists, give me a little clappy. Excited to be here, support single payer, but here to learn. If you already know a ton about single payer and you are really here to like maybe ask some very specific questions, or you are my dad and you are here to troll me, feel free to put the little like laughing emoji on your reactions just so we can get an idea who's joining us today. If you're on a phone and you don't have access to the reactions, I apologize. But for those of you who are able to throw those in the, I see some claps, I see some thumbs up. Okay, so probably coming from different places, and that is perfect. So I'll kick us off for those who are really very new to this and learning this term for the first time with a little bit about what single payer is. And certainly, like, as we go through the Q&A, feel free to ask whatever questions you have. I probably couldn't have answered this question only a couple years ago, so there's no question that we'll hear today, I'm sure, that I haven't asked myself in the last few years. So really feel free if you need a little bit more detail on any of this to use that time. So in terms of what single payer is really a single public agency financing healthcare or organizing the financing of healthcare. And the intent of that is to include all medically necessary services. So medical services like an inpatient stay in a hospital, an outpatient visit maybe with your primary care physician, dental, vision, which right now, if you are employed somewhere, you probably know these are often separate benefits that you have to think about and sign up for. This would all be included. Prescription drug coverage, which I know this group is particularly interested in. So instead of having to pick a separate like Part D plan in a perfect single payer system, you would have that automatically included. That wouldn't be a separate enrollment. Everyone would get that. Medical supplies should be included, long-term care should be included, and it covers everyone from birth to death. So not those gaps in coverage. I know we had a couple of people mention they were recent graduates. You're probably starting your first job, or maybe you're starting your residency and having to pick an insurance plan. Maybe you've already transitioned off your parents' insurance plan or whatever you were doing previously for coverage. So I think one of the really key points of a single payer system is that there is no gap or transition period either there or when people move from job to job, that everyone has consistent coverage from the moment you're born until the end of your life. Some other features of single payer, so there's no cost sharing. That means no copays, no deductibles. But one thing that it's not a national health system. So it organizes the financing of healthcare. It doesn't replace the private businesses that exist today. So this isn't that the government would now run your independent pharmacy. This is really more related to the financing piece of it. And I think a question that comes up for those of you who've maybe never heard the phrase single payer before, you probably have heard the phrase Medicare for all. And I think that this is something that's worth just touching on briefly. So there are two proposed Medicare for All acts. There's one in the House, there's one in the Senate. If you'd like to hear more about kind of how those two compare, how they match up, we can certainly get into that in the Q&A section. And I would say that they're both really a lovely framework for establishing a single payer system, but neither one's 100% perfect example, and there are some differences between them. So I think that it's a great launching point for this conversation, but I think if we were to get to a point where Medicare for All passes, the people who are really excited about and advocates for single payer will not be done with their work, right? There will still be improvements to make and things to do, and ways to continue to enhance that system. So kind of transitioning from that definition into how this would impact pharmacy, there's three big areas that I want to touch on. The first will be drug pricing and big pharma. The next would be PBMs, formularies, these concepts of steering and spread. And the last that I want to touch on is the pharmacist's role in our relationships with patients and with other healthcare professionals, and how that looks in our current system versus how that might look in a single payer system. So in terms of drug pricing and big pharma, I started here because I think this is maybe the most obvious one. And when I talk to my friends who are physicians, or other folks who are non-healthcare professionals that are interested in single payer, this is usually what people want to talk about first. And I think there is really a lot of good content to cover here. But certainly isn't the only focus or the only place where these kind of changes would be really meaningful for pharmacy. So to just kind of set the stage in our current system, I don't think this will surprise anyone. Drugs are more expensive in the US than any of our other peer nations. That's both the wholesale cost of drugs as well as the cost to patients. So if you look at other countries on average, we're just nearly double that in this case in terms of what we're paying for prescription medications. And the prices of medications are rising. So this was, I pulled a few examples here out of an article in JAMA Open Network. There's a ton more if you want to check out that citation to see which other brand name drugs were included there, but I figured these would be a few that all the pharmacists and pharmacy students in the audience would recognize pretty quickly. So the price of brand name drugs during the time that this study was conducted, or the time points this study looked at, went up tremendously. So that average increase in price during a 5-year span was 76% increase, which is wild, right? There's no reason that it would cost 76% more to manufacture these drugs. This is truly just kind of taking advantage of the fact that we don't really have a checks and balances system for drug pricing the way that our current healthcare system functions. And one of these that stood out to me, so for folks that are familiar with whether it's single payer or discussions about big pharma pricing or PBM reform even, insulin will probably stick out to you on this list as well as being really a common like rallying cry of a important drug to point to in terms of how our drug pricing system is broken. I think what's remarkable is if you look at some of the insulin products where the manufacturers are really competing with each other, if you were to track this month by month or year by year, you'll see that the spikes in pricing happen almost at the same time. So it'll be sort of one company responding to the other saying, oh, well, this company is charging more now. And it's never going down. It's never, oh, well, this company is charging less now. Let's charge less to be competitive. It's almost as though they together decide that they can get away with charging a higher price as soon as they see their competitor do it. So I think there's a lot of climbs like that with similar products where they do mirror each other during both this time period and then since then as well. The problem with high drug prices is that they do end up hurting patients. So one of the ways that this I think is the easiest to highlight is through cost-related medication non-adherence. We have more than double the rate of cost-related medication non-adherence compared to our next closest peer country, which is Canada. I think people are always surprised when I highlight this because they'll say, oh, Canada has a single payer system though, right? So like, why are they the next worst after us? And they really don't when it comes to medication. So there's a lot of room for improvement in terms of how Canada's healthcare system is structured if you're specifically looking at the medication piece. And I think this is really another important example in terms of why it's critical to have pharmacists involved in the discussion about single payer. Because if you leave pharmacists out of the discussion, you may end up with a model that doesn't really account for some of these prescription drug benefits or other considerations when it relates to pharmacy. And that prescription non-adherence that's related to cost certainly impacts patients of all ages. In this specific study looking at coverage after the ACA, so after that improvement in the system that we had, there are still a number of patients in that working age class, so too young to qualify for Medicare, no longer pediatric patients that at some point deferred filling a prescription due to cost. But if you kind of look at the breakdown of who's doing this, it's folks that underwent a coverage gap, folks that are underinsured, meaning that the cost for their healthcare services over the course of the year is a very high proportion of their income, or that are fully uninsured. So this is disproportionately hurting certain groups of patients. It's not sort of the same flat rate across the board. It's folks that do have uninsurance or underinsurance issues, or folks with gaps in coverage that are most impacted by this. And there's certainly a lot more to say looking at more of the medical side of things about health inequities as well, but this is just a quick spot that I wanted to highlight that, and we can certainly speak more about that in the Q&A if that's an interesting topic for our audience today. So how would single payer help with these things compared to where we are with our current system? So a couple things related to drug pricing that I think single payer would allow us to just dramatically improve right off the bat would be that consolidating power to be able to negotiate with pharmaceutical companies. And when we get to the section on PBMs, we'll talk a little bit more about how that's done now. But one of the big differences in these countries that do have a single payer system is that they can sort of universally say, okay, this product is or isn't going to be available. If you're unwilling to meet our price, then it doesn't have to be on our national formulary. And the amount of bargaining power that comes with that is a lot more than any of these PBMs would have currently. So those negotiations, just sort of consolidating the power for those negotiations, taking that power out of the hands of pharmaceutical companies can really drive down pricing. And I've seen figures anywhere up to like a 50% price decrease on brand name drugs would be expected just from that one change in terms of changing who's at the table for those negotiations. And then the other part of a single payer system is that it removes cost burden from patients entirely. So there's no copays on medications. No one is underinsured. No one is uninsured. Everyone has access to the medicine they need without a copay at the point of service. So that's a huge, huge benefit in terms of the potential for cost-related medication non-adherence. Like that really shouldn't be an ongoing concern in a single payer system. There are some additional things beyond the two Medicare for All bills that I mentioned that could also be helpful in terms of improving patient access to medications, whether that's in the US or in our neighbor country, Canada. These are really interesting. I would say they're maybe beyond the scope of what we're going to talk about today, but if you're interested in some things that could further enhance access to medications for patients, I would suggest checking out this website for a little deeper dive into that. The one thing that you'll hear a lot, so, okay, great, driving drug prices down helps patients, it helps make this whole system more affordable, but what's going to happen to innovation if we're not giving the pharmaceutical companies these huge profits that they're getting on drugs now? Won't they come up with less cures, less treatments? And I think to kind of put that in perspective, most major pharmaceutical companies spend about 15 to 25% of their revenue on research and development. They spend 1 to 2 times that amount on marketing. And the US is actually one of the only places where you can do extensive marketing, at least in terms of direct-to-consumer marketing on TV. If you've ever seen a glossy ad in a magazine, that doesn't happen in other countries. It's just the US and New Zealand that even allow that. So that's a huge proportion of their budget that they wouldn't need to spend in a single payer system because they're either part of the national formulary or they're not. So there's no need to do those kind of advertisements. And that's something that even without implementing single payer would be a great change to make to kind of match, again, our peer countries, because it really truly is just the US and New Zealand that still even allow that. The other place where a lot of money is going that is not research and development is that pharmaceutical companies actually represent the largest lobbying industry in the entire United States. They actually spend 2 times the amount that other insurance companies, including health insurance companies, spend. There is such a great number of pharmaceutical lobbyists, pharmaceutical company lobbyists on Capitol Hill that it is like impossible to walk through there without running into one. It's just absolutely wild. It is one of the best funded lobby groups out there. So that's another place where, you know, this money that's needed for research and development could be coming from instead of just charging patients higher prices. One of the throughout this, I wanted to highlight a couple of things that have happened in 2020. There's certainly a long history of problems with the way we finance healthcare now, to think about and review as you all learn more and think more about single payer. But I wanted to pick a couple current examples. So the first one that came to mind for me when it comes to drug pricing was Gilead, especially because this is very timely with remdesivir for COVID. So Gilead is an interesting company if you look back even within the last 10 years at their history. So they're really known for earning billions, literally billions of dollars annually on the sale of their drugs. And some of their highest earning drugs were created with taxpayer money. And this is really not uncommon. A lot of drug studies are funded through NIH grants or other forms of taxpayer money, essentially going into research and development, especially in early phases of trials for medications that later end up being marketed by these large pharmaceutical companies. So if you're ever curious about the story of Spaldi and Harvoni, these are known for being thousands of dollars a tablet, and compared to other countries where you can probably get a tablet of Harvoni for $1. How did it come to be that way? How did we end up here when it was US taxpayers that actually funded the trials for that? There's podcasts on this topic. It's absolutely fascinating. Same thing with Truvada, which is being used for PrEP now. Again, Gilead really relying on studies that were funded by taxpayers to then turn around and market this hugely profitable medication. So I think we kind of saw the same thing play out as we should have expected in 2020 with remdesivir. And I think there's been a lot of discussion about, is the price point appropriate? Is it not? Well, patients will never see that price. And it's true, right? For those of you who work in an inpatient setting, patients generally don't see the cost of a specific drug show up on their bill, right? It's probably billed as an ICU stay and their insurance covers it. I'm not sure how true that's going to be in this new kind of world. As we live through the pandemic, if you don't have insurance coverage, then you probably are responsible for every line item. And we know that millions of Americans are losing their insurance coverage during this pandemic. So I think that saying that the cost of remdesivir is hidden to patients because of the fact that it's given in an inpatient setting is probably not as true as that might have been even 18 months ago. And I think the other piece of that is, even if it is hidden from patients who are insured, that really then ends up hurting hospitals who are providing this care and administering that at a time when we should be protecting and making sure that hospitals in smaller communities or rural communities are staying open and that patients have access to those places. So it's really just, it's a lot of profit for Gilead at the cost of potentially patient care, and sort of the health of our hospitals in this country. And I think this kind of also brings up, what should we expect with the vaccine? Or is it going to be the same story? What are we going to do to control the price of this? We thought that Gilead was going to price this drug fairly based on how much taxpayer money went into it. For whatever reason, we thought that, even though we knew their track record, right? Can we expect that things will be any different with the vaccine? Is that going to be affordable? Is that going to be something patients can get access to? And what are the public health implications of that going to be? So that was really what stood out to me this year when it comes to drug pricing. Some other things that certainly influence drug pricing and influence access and affordability for patients are PBMs and the policies that they have in place. So I wanted to spend a little bit of time introducing what PBMs are, because I know this isn't necessarily always covered in pharmacy school in a lot of detail, and then how some of the practices that they have can impact just outcomes in our healthcare system, I suppose. So pharmacy benefit managers is what it sounds like. They manage prescription drug benefits, and they do this on behalf of large insurers. So if you think of Aetna or United Healthcare, they work with PBMs to manage their prescription drug benefits. PBMs also currently do this for Medicare Part D plans. And then they do this sometimes for large employers that want to work directly with the PBM rather than pick a prescription plan as part of the health insurance that they offer to their employees. So there's a lot of different places where PBMs can get involved. or have their contracting. I thought that this diagram was somewhat helpful to show. It is super busy, but I think to me that's part of the point. So PBMs are kind of in the center of everything that's happening here. And you'll notice the patient isn't anywhere on this graph, which also I thought was kind of the point. So PBMs are doing those negotiations that we mentioned earlier with drug manufacturers. It's not as though there's one PBM. There are 5 major and dozens of minor PBMs doing those negotiations with drug manufacturers. So again, that idea of that not really consolidated negotiation power coming from multiple different places. They then work with the healthcare plan to pass along whatever their negotiated rebates are. Some percent of those we don't really know. That's not a really transparent process. The health plan pays them back for every prescription with fees and the payment for the drug itself and dispensing fees. That amount is not what the PBM sends over to the pharmacy. What the PBM sends over to the pharmacy is usually much lower than what they're getting for the health plan. So the amount that your pharmacy sees for a prescription versus the amount that the health plan thought they were paying you for a prescription, the difference there is something called spread. So if you hear folks that are really into PBM reform talking about spread, that's what that is. So what functions are PBMs really offering there? There's a lot of arrows going in a lot of directions. So I actually pulled this list off of the PBM lobbying group's website to see what they think they do or what they would tell you they do. So there's a few things on their website that they list as being primary functions of PBMs that relate to sort of cost reduction of drugs. And that is, I have those listed here, and I just want to quickly compare how PBMs do that versus how single payer would be able to do that. So for drug cost reduction, formulary management is really the biggest thing that I think we think of when we imagine what a PBM is doing. They do that, right? They contract with different manufacturers of pharmaceuticals, figure out what's going to be on formulary, and there are thousands of different plans. You have no idea which plan is going to cover what, right? As the pharmacist, as the physician writing the prescription, you're just guessing what's covered on that plan in the majority of circumstances. Single payer would also have a formulary, but it would be one consistent, transparent formulary. You'd know before the patient shows up at the pharmacy what's covered and what isn't, what's part of this plan. And then for folks that did need something that's not part of that pharmacy formulary, there would be a clear exceptions process. It's not like now with thousands of different plans with different turnaround times, different processes for appeals. It would be one clear system. The negotiating power idea I've already talked about quite a few times, but not having these different prices for both the rebates and manufacturers and PBMs, but also for contracts with pharmacies. There's no reason that their in-network pharmacies should get a higher payment than an independent pharmacy for filling the same prescription, the same exact drug. And that kind of brings me to the next thing that PBMs do. So they create restrictive networks. Their lobbying group will tell you that this is beneficial. I don't think that it is, and I think most pharmacists would agree that your patients should have as many options for where to get their medications as possible. And we'll kind of talk about some examples of that from 2020 in just a minute. And then there's also something else PBMs say that they do, which is reducing waste and improving adherence. The way that this is tracked, I think that that's highly questionable at best. And I think that that's something that could also be done really easily in a single payer system, especially when we think about cost-related medication non-adherence. So I don't think that PBMs are offering anything extra or superior in this area. One thing that I do think is a unique function of PBMs, which it's really interesting that their lobbying group doesn't even list this on their website, they do pharmacy claims processing. So this is what PBMs were originally invented for. This is the point of having a PBM when they first came into existence, was that you could process thousands of claims per minute electronically in real time and be able to know what someone's copay was. And I think that that sort of skeleton or that infrastructure, that still needs to exist somewhere for pharmacy billing to continue to happen in real time. But that doesn't need to be owned by PBMs, right? Like that could be owned somewhere else and housed somewhere else. But I do think that's a unique function that doesn't get enough discussion in these conversations. So some lessons from 2020, I think some things we saw were that patient choice and flexibility were really absolutely key this year, and a lot of patients didn't have choice and flexibility. And that was maybe for those of you who are also in Chicago, you'll probably remember some of the pharmacy lootings and temporary closures that happened this spring. That was a huge issue for patients that were locked into only specific pharmacies, right? Like if the one Walgreens in your neighborhood is not open because of whatever, and this, you know, could easily happen in other areas during natural disasters, right? An earthquake, a hurricane. If your one in-network pharmacy in your area is not open, how are you getting your meds? So that was a huge issue this year in Chicago, and I'm sure in other places as well. Another disruption in terms of access to medications for a lot of patients was those folks that are needing to do mandatory mail order, and this is ongoing right now, as there were disruptions to the US Postal Service. Patients are receiving their medications late, they may be lost entirely and needing to be replaced, and not giving patients the option of filling that prescription at their local pharmacy can create gaps in care and gaps in therapy that really could have been avoided by not having these really restrictive, narrow networks with these very specific plans or rules about mail order use and things like that. Another important lesson from 2020, I think that because of those narrow networks that we talked about, we've seen even before the pandemic a lot of pharmacy closures, and that's primarily impacting independent pharmacies who either are being cut out of networks or being reimbursed at much lower rates than the chain pharmacies that are owned by PBMs. And it's really driving this increase in pharmacy deserts that specifically impacts rural communities and low-income communities in urban areas. So I think this is something that we're still going to see the full impact of during the pandemic. And there's an article kind of that really caught my eye that I've got referenced below, but I think one of the biggest areas they highlight as being seriously impacted by those pharmacy closures will be the need for wild-scale administration of vaccine during the pandemic. So I don't think we've seen the story fully play out there, but that's another very current and relevant concern related to pharmacy closures and sort of those practices that can drive pharmacies out of business. And the last thing I want to touch on just very briefly is how our current healthcare system impacts pharmacist roles and relationships. So there's a great article in The Nation that a pharmacist was quoted in just describing how frustrated patients get with the costs of their prescriptions. They don't necessarily understand their insurance plan, and often it's put on pharmacists in community settings to have to explain that and explain, well, you have a deductible, and then, oh, your copay has changed throughout the course of the year for this reason or that reason. And we're kind of put in this position where whether it's actually having that conversation directly with the patient and trying to explain why their copay is what it is, or maybe that's the time you're spending on the phone with the insurance company, trying to get an override, trying to figure out why you can't process this claim. But there are all these little sort of things that take away the time that pharmacists should be using for patient counseling and for building relationships with our patients and making sure that their medication is safe and effective. So for those of you that have worked in a community space, I would challenge you to think about how different your workday would be if you never had to call an insurance company again, if you never had to explain a copay or collect payment again. If every single prescription was just covered at the point of care fully for that patient, there weren't a bunch of different plans to know and overrides to memorize, but just one clear, consistent formulary, how would that change what you could do in your day? What different services would you want to provide? What different things would you be able to offer to your patients? So I think that's something that I don't have all the answers, and I have intentionally left that section really brief because I hope that some of the pharmacy students in the room will think about what they would like that to look like as their careers progress. So that's everything I had now. Kristine, if you want to take the reins and open up the panel, I saw that we definitely had some comments coming in the chat, and I have not reviewed any of those yet, so hopefully we can get to some of those next.
Yes, thank you so much for that presentation. That was great. We had a question from Paul, who is the single payer? So anyone can answer this question.
I'd be happy to take that one. The single payer is the same payer that pays Medicare, the same payer that pays Social Security. So while you could think of that as being the government, what it really is our taxes that that the government then distributes for us. So it's actually a sort of a publicly run organization, but it would be the same as for Social Security or Medicare, which has worked tremendously effectively. As one who is now receiving both Medicare and Social Security benefits, I can tell you it works really well. The administrative cost for traditionally run Medicare, their administrative overhead is somewhere around 2 to 3%, whereas we didn't get into this, but Medicare Advantage is Medicare that is privately administered, and their administrative overhead is somewhere in the 17% range. Does that answer the question?
Paul responded, trying to be clear, Medicare and Social Security are government programs. Yes.
Yes.
Yeah, absolutely. And I think that we certainly, like from the pharmacy lens, see a lot of success with government-run programs compared to privately run programs, whether you're talking about I know for Medicare and pharmacy, that's actually not our best example because of the way Part D is run through PBMs, but we do have a government insurance example, which is TRICARE, right? Or the VA's coverage and benefits. So if you look at studies for almost any disease state that's been looked at, but I know COPD is probably a hot one when you're thinking about the VA, the rates of medication non-adherence related to cost and just overall in patients that are covered by the VA are so much lower than those that are covered by private insurance. So I think it's tough because the example of Medicare doesn't work quite as well in the pharmacy world just because of the way prescription drug benefits are structured, but I think we do have that really lovely example because of the way those prescription benefits are structured in the VA. And that's usually one of the best working systems, although I will say the amount of reliance on mail order right now is an issue.
Kristine, can I add one more thing?
Oh, yes, go ahead.
I just heard this happen, Shannon, and I love that it happens so often, and it's a correction I really want to make, and that is using the comparator to a government-run program, having the comparator be privately run. Those are not the same thing. The comparator for a government-run program would be a corporate-run program. The comparator for a private program is a public program. And so I loved in your first slide, Shannon, when you described Medicare for All or single payer as a public agency. That's what it is. If you're going to call it a government-run agency, then compare it to a corporate-run organization, not a private one. When we make that false dichotomy, those are powerful words. They're very, very emotionally charged. And private, nobody has a problem with private. But boy, say government run.
I think that's an important distinction. Thank you for clarifying that. And my rotation this month is actually at the VA. So having been there for a few weeks now, I definitely agree with what you said, Dr. Rotolo, that it is a lot different than handling private insurances, and definitely makes our job easier and patient care go a lot more smoothly. See, the next question we have is from Kava, and they ask, can you talk about what other healthcare professions are lobbying for single-payer healthcare and how collaborations have gone in those efforts? We're severely limited in terms of lobbying compared to pharma companies, and I'm curious to know possible solutions to that.
Sure. So Dr. Paris, I'll let you talk a little bit more about PNHP as an example of a different group of healthcare professionals. But the other one that I guess I'll quickly highlight is National Nurses United is definitely extremely supportive and very vocal about their support for Medicare for All. I think in terms of room for collaboration, so I know not through, since we as Pharmacists for Single Payer are a very new organization, but through other sort of state-based organizations that I'm in that are supportive of single payer. National Nurses United has been a great group to work with on organizing rallies and protests, and is very welcoming to other folks being involved, and has been a great group to work with. And then PNHP has also been, I know Tom and I in our experience, extremely welcoming to pharmacists, extremely valuable in terms of the resources that they've connected us with. But Dr. Paris, if you want to talk a little bit more about PNHP and what they do.
Well, the one thing I'd like to point out about PNHP, our name is Physicians for a National Health Program, but we do welcome all professionals and others, consumers into the organization. One of the things I'm most proud of is the number of student chapters we have. It's called SNAP, Students for a National Health Program. We now have chapters in over 90 medical schools across the country, and I would love for, and I think the SNAP chapters very much welcome all of the health professions. So please, if you're a student in pharmacy, find your SNAP chapter and join it if this is something that you're, excited about. One of the things that that the Students for a National Health Program succeeded in doing last year was mounting a protest at the AMA convention in Chicago, and they successfully got the AMA to withdraw from the Partnership for America's Healthcare Future, which is like the pharmaceutical lobby on steroids. The pharmaceutical lobby is a member of the Partnership for America's Healthcare Future, as are the American Hospital Association and many other. And the AMA was also a member until students protested and said, get out. So I'd love to have pharmacy students protest and say, pharmacists, get out of the Partnership for America's Healthcare Future.
Mm-hmm. Yeah, I was at that rally, and it was a great experience, and obviously effective, which was cool because you don't always get what you wanted at the end of a rally. So that was a really great experience. But yeah, I didn't run into a lot of other pharmacists there. So I think pharmacists are definitely very new to this conversation and this discussion. And I'm hopeful that when there does come a time that we're able to have those kind of large events in person, that we'll have more pharmacists involved.
Thank you. I think another one of our members, Mira, has something to say about this. So feel free to unmute yourself.
Hi guys, thanks so much. The comment I wanted to make is that just a Kavia's question is that we do currently also have lobbyists and perhaps lobbying groups on a much smaller scale, but in that both happens at the state level and to some degree in Washington, but yeah, so those that we have lobbyists in place, of groups that are supposed to be representing us, meaning pharmacists in our profession. And so to some degree, it is up to individual, like if all the pharmacists or 90% of the pharmacists in a particular state were to start personally calling their state organizations or other, APHA, SHP, and expressing, why they support single payer, then those are the groups that represent us. Those are the groups that we pay dues to. And so if a bunch of the membership is supportive of these ideas, then lobbying efforts may eventually start being channeled towards supporting these ideas on a state or national level. So I wanted to point that out. We do have lobbying groups. It's just they're obviously much smaller and may vary by state. The other thing I wanted to point out, just to the previous question that was being discussed, I think it's important to make a distinction between government run and government funded, because that's really key, right? So you have systems like in the United Kingdom, where you have a fully governmentally run healthcare system, meaning the government is the payer and every employer within the healthcare system is an employee of the government. So that is 100% government ran, right? That would be similar to like the VA. But on the flip side, government funded, which is what Medicare for All, as it's been proposed in the Senate and the House currently, is proposing, is a government funded healthcare system that still exists in the context of privately ran hospitals, private providers, meaning private physicians, pharmacists, nurses, etc., private, hospitals, which is how our current Medicare that currently exists for seniors and disabled folks works. And so that's a pretty big distinction. So when people say, I don't want government running my healthcare, well, government wouldn't really be running it. So just want to point that out. Thank you so much.
Thanks, Mira. That's super helpful. I think, like, to your first comment about, pharmacists needing to really put pressure on our organizations to achieve changes. APHA this year, for like the first time I can remember it being a really big deal, is talking about PBM reform, right? That didn't come from like the random board of directors at APHA being like, oh yeah, we really should do something about these PBMs. That came from pharmacists calling in and saying, this is a problem. I'm closing my pharmacy. This isn't working. I'm not getting reimbursed for even the cost, like, of what I paid for this prescription, never mind enough to keep the lights on too. And now APHA has taken that up and they're very vocal about it, even within the last 6 months, more so than I ever remember in my career as a pharmacist. So I think Mira's point is really important, that like it's on us as members of these organizations that represent us to push them in the direction we'd like to see things go.
Our next question is coming from Tashreek, and it is, how would we implement a single payer healthcare system? Would it take several years?
This is a great question, and this is where the bills do differ in terms of what's currently been proposed. So Dr. Paris, correct me if I have this backwards, but I believe that the House bill has a 2-year transition period, and the Senate bill has a 4-year transition period. So that's there are a couple things that I like better about the House bill, and that would be one of them.
That is correct. So that is how long it would take to implement the bill once it has passed and been signed into law. And even 2 years is probably longer than it really needs to be. We enacted traditional Medicare in 1965 in 1 year, and that was basically without computers. So it is quite possible to do it. But is that the question, or is the question, how long is it going to take to pass the legislation?
Yeah, I think those are two different questions, so you can address both. I think passing legislation, is is a separate issue than actually implementing the program.
Because it's easy to, 2 years or 4 years, depending on the legislation, to implement it. How long is it going to take to pass it? That's anybody's guess. But what I like to say is, did anybody know that the Berlin Wall was going to come down the day before the Berlin Wall came down? Not really. So I think our job as citizens and as health professionals is to not only educate our patients and turn them into spokespersons for their own best interests, but it's also our job to make it politically toxic for our members of Congress not to do what we want them to do.
Absolutely, I agree. Get any more questions? Oh, I have a question since no one else has. So can you explain how this would affect the pharmacists, like working conditions, especially for community and retail pharmacies right now?
Sure, yeah. So I think what I had alluded to, I think the biggest change that I see happening would be related to reimbursement rates truly on prescriptions. So that, I think, in terms of being able to keep independent pharmacies in existence and not have PBMs steering patients away from them, and being able to keep pharmacies in our communities and not have PBMs steering patients to mail order only. To me, that's probably one of the key or critical pieces there. But I also kind of that last slide, what I was alluding to is, if you had all your time free to up that we currently spend fighting with insurance companies, even in my role, right? Like I don't work as a community pharmacist. I work at a large academic medical center, but geez, probably half my day is fighting with insurance companies, filling out PA forms, doing appeals, right? What could I be doing with that time instead? I'm a pediatric pharmacist by training. I should be able to really be optimizing care for my patients and spending all of my time making sure that their therapy is going to be safe and effective, right? That is what we go to school for, to make sure that drugs are going to be safe and effective for our patients, to make sure we're optimizing whether or not they're able to be adherent to those therapies, to make sure we're making adjustments when we need to, and I think that that's true, whether that's in the community pharmacy setting, whether that's in the hospital pharmacy setting, really any practice area. Your time should be spent taking care of patients, not figuring out how they're going to pay for their meds. And I think it's consuming a higher and higher percentage of what pharmacist time is being used for, and it's very important, right? I can recommend the best thing for a patient, right? I used to say this when I precepted in the inpatient setting. I would tell my students, you can recommend the perfect vancomycin dose, but if a 20 milligram different dose is what's in the Pyxis, right, or in the Omnicell that's on that floor, and they would have gotten that immediately, and it's now going to take the IV room 4 hours to make it because they're backed up or someone called in sick today, then you actually didn't do the best thing for your patient. So you can have these fantastic clinical recommendations, these perfect clinical recommendations, but if your patient can't get the drug, it doesn't mean anything. So I think that the sort of corollary to that feeling or vibe that I always had in that inpatient setting, it's the same thing on the outpatient side, and it's usually cost and potentially just sort of points of access that are controlled by these payers in the game right now that prevent that beautiful recommendation, that perfect plan for that patient from being able to be followed. So that's really what I'd like to see pharmacists doing is using our training in the way that we're meant to help our patients instead of just fighting with insurance companies and rules that don't make sense.
And I'd like to add a few more onto this, if I could. And first, with the single payer system, I think it has the greater potential to address many of the health disparities we see that are based on race, ethnicity, and income. and pharmacists are very interested in that. There is a lot of pharmacists that are interested in that. And I think, that's an important aspect that has to be emphasized. And in addition, independent pharmacies, they're small businesses. And as small businesses, they are also providing health insurance for their employees. And the cost of that health insurance just keeps rising and rising. And I have some numbers. I pulled them out. I wanted to be prepared in this aspect. The Kaiser Family Foundation in 2018, the average employer contribution. So this is just from the employer for an individual health policy. So for a single person, a single employee, the employer's contribution was $5,288, and the average employee contribution was $1,427. And now the next step is if you have a plus one, employee plus one. So if there's a couple that is on an insurance plan, the average employer contribution was $9,791, and the employee's contribution was $3,634. And then when you look at the family plans, now you have the average employer contribution. And remember, this is for each individual. This is for each employee. So if an employee has a family, the contribution from the employer was $14,134, and the average employee contribution was $5,431. And it's also important to remember that these are not including deductibles, co-pays, co-insurance. It's the amount of money that's spent on that end. So as a business, you can think that, what can I do with all that money instead of paying it to insurance companies? And you can pay employees better. You can do other things with your business. A lot of things you can do with that money. And yes, I think when people say, "Oh, my taxes are going to go up if we have a single payer," I think the important argument is to think, well, what is your total amount that you are paying overall? What is that going to be? And it's going to be less because things will be more efficient, and a specific tax may be higher, but your overall money going out of your pocket is going to be substantially lower. And that's going to be an important thing to keep in mind. Thank you.
That's an excellent point. This is Mira. Both of those have been excellent points. I just wanted to add one more when it comes to, so I do want to say, I feel like the argument for single payer, first and foremost, based on ethics is what's for me the strongest, because currently we have a system that rations care, and we know that outcomes for folks who are on the lower end of the spectrum, economic scale spectrum, have much worse outcomes, die at a younger age, etc. So that is, I think, by far the strongest argument. But even from a selfish, let's say, personal perspective, I think that, so for-profit and healthcare are inherently at odds with each other, right? Because the goal of a for-profit system is to make profit, whereas the goal of a healthcare system should be to keep people healthy. And that means that you have enough care providers to care for people. Whereas on the for-profit ends, you want to minimize the amount of staff that you have, right? You want to optimize leniency and all that. And what that has really translated to over my decade in practice, and this is something that does not get discussed much at all, is really we're moving towards like exploitation of workers within healthcare. And that applies to pharmacists, my goodness, to physicians. Like I see it across the board, to nurses, to everybody. So I started off my pharmacy career exploring really pharmacy as a pharmacy technician about 15 years ago. And the practice back then and the practice that I have seen working kind of per diem in retail for a little stint is just drastic and dramatic. So what has happened over the past decade is pharmacists now do not have the time in the retail setting to reach out, say an antibiotic gets prescribed for an infection, and it's not covered by the insurance. A lot of pharmacists, at least in the chain that I worked for a little bit, don't even have the time to make that call to the doctor to say, hey, we gotta get this changed to whatever else is covered. And so you can obviously see the problem with that, right? If someone has an acute infection that isn't treated, that you have to wait for the doctor to see the facts and to get back to you in a couple of days with a new antibiotic, like that infection could get worse. The patient could end up in the hospital. If it's a blood thinner and someone needs to be on a blood thinner because they have a clot, say, in their leg or their lungs, that could kill them if they're not, if they don't get on the medication or stay on the medication, I should say, then that could like it lead to the patient dying. Pharmacists don't have the time currently in our current system and in the pressures that are exerted on our colleagues in the retail setting, especially to do that, to clarify those medications in a timely manner, and that hugely impacts patients. But pharmacists are just so stressed, there's no time. There's just no time, and it really, exploitation is not too strong of a word. I have seen the same thing with my nursing colleagues in the hospital. I've seen the same thing with with our physician colleagues. It's happening across the board. So even from a very like selfish perspective, like in a way, if you will, it will a single payer system that is focused on care and optimizing care and wellness instead of how can we squeeze people for more profit will benefit everybody across the board.
Mira, I can't agree with you more. And I don't think exploitation is too strong of a word at all. And I know in the MD literature, and probably it shows up in the pharmacy literature too, they may talk about, physician burnout or pharmacist burnout. I take exception with that terminology. Burnout sort of implies that there's something wrong with me. If I have burnout, it's because I didn't get enough sleep, or I'm not meditating enough, or I'm not doing enough yoga. But the term that I think is way more accurate is called moral injury. And what moral injury says is, if I as a clinician am suffering from stress, it's actually an expected outcome from an absolutely unacceptable situation. And it's the system that needs to change, not me. I don't need to get more sleep and meditate and sing Kumbaya. I need a system to change so I can practice in a way that allows me to put my head on the pillow at night and feel good about what I've done, instead of anxious about all the examples Mira just gave in her very eloquent remarks.
Yeah, thank you so much for all of your comments. I agree, like what would definitely contribute more to my burnout or lessening my burnout would be not having to worry about being healthy and affording health care and providing care to people. So we have time for 2 more questions. So I'll just read them out quickly. So one is from Alyssa Wu. Is this aimed for everyone at any health condition or age, or is it like Medicaid or Medicare that has certain criteria and able to be enrolled?
So it's really aimed for everyone, birth to death, from the moment that you are born to the moment that you die. There'd be no gaps in coverage. You don't need to do anything special to qualify. You qualify because you're a human being and you deserve health care.
Everyone in, nobody out, right?
All right, our next question is from, I lost it. It's from Andrea, who could not be here today, but she asked, would we all have to use one EHR system, and would it change the way which we build the systems already in place? I think that's an interesting question.
It's a really cool question. So again, with the idea that it's not government run, so I don't anticipate that you'd be mandated to use one specific EHR, although actually that would maybe be nicer in a lot of ways, in terms of like clear documentation in one place, and all of that. It may change how we utilize the EHR, right? Like if there's only one payer, that might make it a little bit easier to place a note instead of having these weird note templates that we use in hospital settings, where you're like trying to cover your butt for every possible thing that might need to be checked for billing. The idea of maybe using global budgeting for hospitals, or some of the ways in which billing could change might simplify how we use EHR systems for sure. And then in terms of other billing things, so kind of what I'm picturing in a community pharmacy is just billing to one place, sort of like the hub, right? Like you're not billing this bin number for this plan and this group number for this plan and this PCN, and like, let me figure out what their ID is. It's been the same their whole life. There's not like a changing card every time they switch jobs, right? And you're only billing to one place. So that's somewhere where I actually think, even though there might not be one EHR, wow, like for folks that study, you know, whether that's medication adherence or other things, that would be a potentially very data rich system, which could give us a lot of information about public health as it relates to medications in that way. So those are some of the things that come to mind for me, but I'm sure Dr. Paris, you've probably answered this question more than I have.
Well, no, I thought that I agree with you. I mean, many people refer to them as electronic billing records rather than electronic medical or health records, because if you actually look at the functionality that is built into it, it's all for collecting data for the purposes of billing. And then each of these electronic health records claim, I forget the term for, you know, that they don't want to share data because it's what's the word, you know, private property.
Protected health information.
Yeah, it's ridiculous. So for the one thing, well, HIPAA, but also if it's a private company, they don't even want to share how they gather the data, because it's almost like it's a company proprietary. Thank you, Mira. God bless you. You get to be my, words just don't come sometimes. So I think having an electronic record whose actual purpose is to improve patient care and the collection of data for the purpose of good public health and research, all for it. And around your issue of billing, one of the numbers I love is that the Duke University system has 950 hospital beds and 1,600 billing clerks. Almost 2 billing clerks per bed. That is not the case in Canada.
That is wild. So I think that's all the questions we have today. Thank you so much, Dr. Paris and Dr. Rotolo, for being on the panel and presenting today. Tom, do you want to close out, maybe plug our social media and things like that?
Sure, thank you. And thank you, Shannon, for a fantastic presentation. Really appreciate it. And thank you, Dr. Paris, also for participating, you know, to answer the questions, and for everybody who was on to the program and for the questions you gave. It was a really good conversation. Really appreciate it. I put it up in the chat that our organization, you know, we're kind of just getting the ball rolling a little bit more, and we don't have a website fully up yet. I sent out an email. I listed the email where if you're interested in participating, we'll put you on the list. And also there's a Twitter handle as well. So please follow us, and we'll keep moving forward from there. Thank you all very much.
Thank you. This was a wonderful panel. I really appreciate your asking me to participate. Thank you.
Great to be here. Great to have you, Dr. Paris. Thank you, everyone, for joining today. I hope that this was informative. If anyone wants more detail on whether it's the bills or single payer, maybe not related to pharmacy and just healthcare in general, feel free to reach out to us, like Tom said. I know myself and some other members of the organization have done kind of broader talks on this topic as well. So we're always happy to chat with you. I also, like, another thing I love chatting with pharmacy students about is advocacy and how to get more involved. And that's something we opted not to include today for the sake of time. But if you have a student organization and you'd like to talk more about that, I'm happy to come chat with you, or I can refer you to some other people if you're tired of seeing my face. But I think that's a really important topic for pharmacy students that we don't always spend enough time on in our curriculum and education. So please feel free to reach out if you'd like to talk about that more.
Please, oh, please ask me back if you're going to talk about advocacy.
Yes, for sure. We will.
Sounds like we'll have to do this again sometime. All right, everyone, I'm going to close out the meeting now. But thank you, everyone, for being here again, and have a good rest of your weekend.